If you take a damp cloth right now and just wipe off a dusty bookshelf in your home, you are, well, mostly cleaning up dead human cells.
Yeah, it's a pretty gross reality to think about.
It really is. It sounds like a horror movie, honestly. But your body violently sheds and replaces its entire outer armor roughly every 28 days. You leave this literal trail of yourself everywhere you go.
You really do.
And today we are doing a deep dive into the incredible, completely hidden landscape of your skin. We're tracing a map that starts right at the physical surface, looking at the surprisingly violent ancient words used to describe it.
Oh, very violent.
Right, and we'll dig all the way down into the invisible nervous system hiding beneath it, which actually happens to be at the center of a massive ethical crisis in modern artificial intelligence right now.
It's a huge issue.
So if you are listening to this, prepare to completely change how you look at something as simple as a scraped knee.
It's funny, we all think we know our skin because we see it in the mirror every single day. We treat it like, wrapping paper.
Yeah, exactly. Just the packaging.
Right. But how medicine maps and defines and treats that boundary layer is a completely different story.
I always used to look at medical terminology as this, dusty dictionary of dead languages.
Yeah.
But it's really more like a cartographer's coordinate system.
I like that analogy.
Yeah, you have these distinct prefixes and suffixes, and when you snap them together, they give you the exact biological coordinates of a disease or a procedure. Today, we are exploring the coordinates of the skin, which are anchored by two foundational roots, dermato and dermo.
Right, the classics.
But to understand this medical map, we really have to look at the origins of those roots. And fair warning to you listening, the history is surprisingly graphic.
It is very graphic. So both dermato and dermo trace back to the exact same ancient Greek noun, which is derma.
Derma.
Yeah. And this word was heavily utilized by intellectual heavyweights like Aristotle and Galen in their early anatomical writings. However, derma itself stems from a much older, much more aggressive Greek verb, derain.
Okay, and what does that mean?
Derain translates literally to flay or to strip off a hide.
Wow. Wait, to flay.
Yes, exactly.
So right from the inception of the vocabulary, we are dealing with this very literal, visceral image of a layer being forcibly pulled away from a body.
Yeah, that imagery perfectly captures how ancient anatomists actually studied the body.
Yeah.
I mean, through dissection and the literal peeling back of layers.
That makes sense, yeah.
And that ancient Greek origin is also responsible for a grammatical quirk that often trips up anyone trying to decipher a medical chart. Because you might wonder why we have two forms floating around, like why use dermo sometimes, but dermato with a T other times.
That actually always bothered me. Like if I'm plotting my medical coordinates, how do I know whether to include T or not?
Well, it all comes down to the Greek genitive case, which is essentially their possessive form. The genitive form of derma is dermatos.
Oh, dermatos. So that's the linguistic ancestor that handed down the T.
Precisely. And the functional rule of thumb in medical terminology is that you use dermato carrying that extra T whenever the suffix you're attaching begins with a vowel.
Okay, just to prevent a clunky glottal stop.
Right, exactly. So derma plus meritis flows really easily into dermatitis. Derma plus merology becomes dermatology. But when you don't have that vowel clash, dermo acts as just the bare stem.
It's a pretty elegant little bridge. It keeps the pronunciation smooth. But
Yeah.
what I find fascinating is that ancient writers like Galen, they thought of this derma as just one uniform sheet.
Oh, yeah, they totally did.
They just saw the visible surface and assumed it was monolithic. But modern histology has completely dismantled that idea.
Oh, they shattered it. We now divide the skin into three completely distinct, functionally specialized layers.
Right.
At the very top, you have the epidermis, Fe meaning upon. Below that is the workhorse layer, the dermis. And beneath that is the hypodermis, or subcutis, which is, your foundational padding of fat and connective tissue.
Wait, hold on. If the epidermis is just the surface layer and it's constantly exposed to the elements getting bumped, scraped, radiated by the sun, it must take a massive amount of biological energy to maintain.
Oh, an incredible amount.
So how does it survive if it's completely avascular? Because, there are no blood vessels in the epidermis.
Zero blood vessels. It is entirely cut off from the body's main vascular supply chain.
Then it must be absorbing nutrients purely by diffusion from the dermis directly beneath it, like a sponge sitting on damp soil, just pulling up whatever moisture and oxygen it can reach.
That is the exact mechanism. The dermis below is this incredibly rich matrix. It's packed with tightly woven collagen, it's highly vascularized with blood vessels, and it houses all your sweat glands and nerve endings.
Okay.
Yeah, so the epidermis just borrows its nutrients through that cellular boundary, and it uses those nutrients for really aggressive renewal. New skin cells, known as keratinocytes, are born at the very base of the epidermis.
And then over that 28-day cycle you mentioned earlier, they just migrate upward, right? Flattening out, dying, and ultimately flaking off to become household dust.
Exactly. Which gives us a brilliant, practical first aid heuristic.
Oh, right. Like if you are out running and you fall and get a scrape on your knee and it doesn't bleed.
Then you haven't actually breached the epidermis.
Bleeding is the physical, undeniable proof that you have bypassed that top floor and broken into the vascularized dermis. The word epidermis isn't just trivia for a biology test. I mean, it's a diagnostic tool you can see with your own eyes.
It really is. And because crossing that boundary into a deeper layer changes the biological stakes entirely, doctors need highly specific vocabulary to navigate it.
Right. They have to coordinate exactly where they are injecting a medicine or what specific disease process is happening, because the treatments are entirely different depending on the depth.
Exactly. So let's apply our cartography analogy here. The suffixes we attach to dermato or dermo completely change the biological coordinates.
Let's look at the mechanisms behind two common suffixes, germitis and edosis.
Sure, so the suffix atus signifies active inflammation. Dermatitis is an inflamed skin reaction. If you brush against poison ivy, your immune system recognizes the plant oil as a foreign invader and rushes white blood cells to the area. You get contact dermatitis.
So the suffix itis means it's an active battleground. You're going to see redness, heat, swelling, maybe blistering.
Yes, the immune cascade is in full swing. On the other hand, the suffix atus simply dictates an abnormal condition.
Okay.
It doesn't necessarily imply that active inflammatory fire. Dermatosis is a broad umbrella category for really any disease of the skin.
So it's the same root coordinate, two different suffix coordinates, resulting in two entirely different clinical realities.
Precisely. But just when you think you've mastered the Greek map, modern medicine throws a massive curveball.
Oh, the Latin trap.
Yeah, because we didn't just inherit Greek roots. We also have a completely separate Latin family for skin, which is cutaneo, coming from the Latin word cutis.
It's like having two sets of identical keys. One says Greek and one says Latin, and they are supposed to open the exact same biological door.
The dual language trap is, well, it's a well-documented source of stress for first-year medical students.
I can imagine.
Yeah.
But are they actually different? Do they point to slightly different cellular structures, or is this just a linguistic turf war?
It is entirely unscientific. They are true, perfect synonyms. Linguistically and biologically, they point to the exact same tissue.
Wait, really?
Yeah, but centuries of clinical convention and habit have strictly separated how they are actually used.
So it's just sheer tradition that dictates the coordinate system here.
It is. If a doctor is administering an injection into the middle layer, they use the Greek root and call it intradermal. But if they are injecting into the fat layer below, they switch to the Latin root and call it subcutaneous.
Okay, got it.
You will almost never hear a clinician say subdermal or intracutaneous on a hospital floor.
I imagine there are severe clinical stakes to getting this vocabulary right, though. It's not just doctors being pedantic about dead language.
Oh, absolutely. The stakes are patient safety and diagnostic accuracy. Consider the classic Mantoux test used to screen for tuberculosis. That injection absolutely must be intradermal. It has to go precisely into the dermis.
Let me guess the mechanism here. The dermis is tightly woven with collagen, right? So it traps the injected antigen in one spot, forcing the local immune cells to react right there so the doctor can read the resulting bump.
Right.
But if you shoot it too deep into the subcutaneous fat...
The test fails. The subcutaneous layer is a loose matrix of fat and connective tissue, and it has a very different vascular absorption rate.
Oh, I see.
Yeah, if a nurse mixes up those terms and places the TB test subcutaneously, the antigen just gets swept away into the bloodstream way too quickly. The local immune reaction never forms, producing an unreliable, falsely negative reading. Conversely, insulin requires that rapid systemic absorption, which is exactly why it is given subcutaneously. Mixing up the Greek and Latin coordinates can lead to profound practice errors.
It is incredible how much mechanical weight these simple words carry. Having the right vocabulary to name the structural layers is one challenge, but historically, figuring out how to classify the hundreds and hundreds of distinct diseases that stripe those layers, well, that sparked the founding argument of dermatology itself.
Yeah, to really appreciate that argument, we have to look back at late 18th century London. A physician named Robert Willan was working at a public dispensary treating the urban poor. And at that time, skin disease was just utter chaos. There was no
Mm.
shared vocabulary.
So one doctor looks at a patient and writes down, I don't know, blistering heat, while another doctor in the next town calls the exact same condition a weeping scale.
Exactly. A single condition could have 20 different names depending on whose textbook you were holding at the time. Willen realized medicine just couldn't advance like this. So in 1798, he published a rigorous classification system based entirely on morphology.
Morphology, so meaning studying the appearance and form of things.
Right. He categorized diseases strictly by what they looked like to the naked eye.
So his map was purely visual. He basically defined the basic lesions we still use today.
He did. He introduced terms like macules, which are flat, discolored spots. Think of a freckle. Papules, which are small, solid, raised bumps. Vesicles, which are tiny blisters filled with clear fluid. And pustules, which are bumps filled with pus.
Okay, yeah.
By defining these visual building blocks, his student Thomas Bateman was later able to popularize a universal descriptive language across the entire English-speaking world.
Meanwhile, over in Paris, you had Jean-Louis Alibert doing something similar but taking it to a theatrical extreme.
Yes, really did.
He literally painted a massive mural, the Arbre des Dermatoses, or the Tree of Dermatoses, right on the wall of his hospital. He grouped skin diseases into families on the branches of this tree, again, based entirely on visual similarities. If they looked alike, they lived on the same branch.
It was very dramatic. But not everyone believed that outward appearance was the truth. A generation later, in Vienna, Ferdinand von Hebra pushed back aggressively against the Willen and Alibert systems.
Right.
Von Hebra argued that grouping diseases purely by their outward morphology was scientifically shallow and, honestly, intellectually lazy.
Hebra basically says, you're all just looking at the surface, which is a pretty great accidental pun for dermatology, honestly.
It really is. Hebra championed a pathology-first approach. He argued that you just cannot group a cluster of diseases together just because they all present as red, itchy papules. You have to look at the cellular level.
Like, what is the underlying cause?
Exactly. What specific microscopic tissue damage is happening?
Yeah.
He wanted to classify by mechanism, not by visual coincidence.
This is a classic clash of scientific philosophies. You have the Willen morphology camp saying, trust the visual pattern, and the Hebra pathology camp saying, trust the microscopic mechanism. So how did they resolve this? Did one system eventually win out?
Well, the beauty of modern medicine is that it realized both men were half right. Today, dermatology thrives on a necessary compromise.
The ultimate medical truth. Let me guess. They use Willen at the bedside and Hebra in the lab.
You've got it perfectly. Doctors diagnose by morphology at the bedside. They rely on Willen's visual pattern recognition to make their immediate clinical assessment, but then they confirm that diagnosis by pathology.
Oh, I see.
They take a biopsy and put it under the microscope, using Hebra's approach to analyze the actual cellular mechanism.
And this rigorous system of bedside observation, it isn't just for diagnosing a stubborn case of acne. When doctors map out the skin, they are often using it as a window to locate deeply hidden, life-threatening internal diseases.
They are, yeah.
The skin acts as this external dashboard for the nervous system, which brings us to one of the most fascinating coordinates on our map, the dermatome.
It's such a brilliant concept, though the term itself carries a dual meaning that, well, it requires some unpacking. The first definition of a dermatome is purely mechanical. It's a surgical instrument, combining dermato for skin and detome, meaning a cutting instrument. It is a highly specialized tool used primarily in burn units to perform split-thickness skin grafts.
Right, and just to clarify for the listener, a split-thickness graft means the surgeon is shaving off the entire epidermis and just a tiny fraction of the dermis underneath it, leaving enough of the donor site intact so it can heal itself, while using that shaved sheet to cover a severe burn somewhere else.
That's the exact procedure, yeah. The dermatome tool ensures the shaved sheet is uniformly thick down to the millimeter. But the second definition of dermatome is far more abstract and clinically profound. A dermatome also refers to a specific horizontal territory of skin that is wired to a single spinal nerve root.
Let's try to visualize this map. Your spinal cord has nerves branching out of it laterally, like branches on a tree trunk. You have cervical nerves in your neck, thoracic nerves in your torso, lumbar nerves lower down. Each one of those individual nerve roots wires a very specific band of your skin. That horizontal band is a dermatome.
And this invisible neurological map reveals itself during specific disease processes. The most striking example is herpes zoster, which we commonly call shingles. Shingles is caused by the reactivation of the varicella zoster virus, which is the exact same virus that causes chickenpox in childhood.
Wait, dorsal root ganglion, for you listening, that's essentially a cluster of nerve cell bodies acting like a relay station just outside the spinal cord, right?
Correct.
So after you recover from chickenpox, the virus literally retreats and hibernates inside that relay station for decades.
It lies completely dormant in that specific dorsal root ganglion. But when it wakes up, often due to stress or, a weakened immune system,
Hmm.
it doesn't just flood the bloodstream. It travels physically down the path of that specific nerve wire, and it erupts as a blistering rash along exactly one dermatome.
This is where it gets absolutely mind-blowing to me. If you look at a patient with a shingles outbreak, the rash doesn't spread randomly. It wraps horizontally around one side of their torso and then stops sharply, as if a cartographer drew a strict ruler line right down the middle of their chest and back.
Because that midline is the absolute border where one nerve's territory ends and the contralateral nerve's territory begins. The virus is physically incapable of crossing that boundary.
You are literally watching the internal wiring of the human nervous system printed on the surface of the skin.
And anesthesiologists actually rely on this map constantly, but they use it in reverse.
How so?
Well, if they administer an epidural block for surgery or childbirth, they need to know exactly how high up the spinal cord the numbing medication is reached. So they take a cold alcohol swab and touch it to the patient's skin.
Oh. Because if the patient can feel the cold on their collarbone but not on their belly button, the anesthesiologist can pinpoint the exact nerve coordinate that is blocked.
Precisely. The umbilicus, or belly button, predictably corresponds to the T10 thoracic dermatome. The nipple line corresponds to T4. By reading the surface map, they actively verify the internal block.
The skin is an alarm system for far more than just nerves too, right? Dermatology often uncovers incredibly severe systemic conditions.
Many people assume dermatology is primarily cosmetic, but they deal with brutal systemic failures. Take xeroderma pigmentosum.
Zero meaning dry.
Right. It's a rare inherited disorder where the mechanism that repairs UV damage is just broken. Normally, when UV light hits your skin, it literally cross-links and damages the DNA in your cells, and your body deploys enzymes to snip out and repair those mutations.
But in xeroderma pigmentosum, those cellular scissors are just missing, so every single minute of sun exposure accumulates permanent DNA damage.
Resulting in a massive risk of aggressive skin cancers, sometimes appearing in early childhood. Or consider scleroderma.
Sclero meaning hard.
Exactly. This is an autoimmune disease where the fibroblasts in the dermis go rogue and start overproducing collagen. The skin progressively thickens and hardens like wood, and it doesn't stop at the surface. That same excess collagen mechanism can eventually freeze internal organs like the lungs and esophagus.
Or dermatomyositis. Myo meaning muscle. The immune system violently inflames both the skin and the internal muscle tissue simultaneously.
Yes, that's a terrible one.
And it often announces itself with this highly distinct visual cue. A violet, purplish rash around the eyes, called a heliotrope rash, named after the purple flower. If a doctor spots that specific visual pattern on the surface, they immediately know the patient's internal musculature is under attack.
Accurate visual observation is a matter of life and death. You have to be able to read the morphological patterns flawlessly. Which actually brings us to the modern frontier of dermatology.
Right?
Because just as Robert Willen and Ferdinand von Hebra struggled to perfectly categorize the visual patterns of skin diseases centuries ago, today's artificial intelligence is facing the exact same challenge.
And the ethical stakes of how we map this data are massive.
The current debate really ignited in 2017 following a landmark study out of Stanford led by Andrea Stava. They trained a deep learning AI system on a dataset of nearly 130,000 clinical skin images. The results were initially heralded as a revolution. The AI literally matched the diagnostic accuracy of board-certified dermatologists when evaluating skin lesions, including life-threatening malignant melanomas.
Okay, whenever I hear a tech breakthrough that perfect, I immediately look for the structural flaw.
Naturally.
AI doesn't have medical intuition. I mean, it only knows the data it is fed. What was the blind spot in the Stanford data set?
The mathematical reality was that the training data skewed heavily toward lighter skin tones, specifically the lighter end of the Fitzpatrick scale.
For context, the Fitzpatrick scale is a numerical classification system used to describe human skin color and how it responds to UV light, ranging from type I, which is very pale and always burns, to type Sex, which is deeply pigmented.
Exactly.
So the AI was basically studying a map that only showed half the world.
When independent researchers later audited this generation of AI tools, they found that the diagnostic accuracy absolutely plummeted when the algorithms were asked to evaluate melanomas on darker Fitzpatrick skin types.
Let's break down the mechanism of why that happens. AI doesn't look at a mole the way a human doctor does.
No, not at all.
It's not seeing a biological structure. It's looking for pixel contrast and edge detection within a grid of numbers. If the algorithm is only trained on high contrast images, like a very dark mole on very pale skin, its mathematical baseline completely fails when it encounters a dark mole on dark skin because the contrast ratio is entirely different.
That is the exact technical failure. The AI science, the actual deep learning architecture, was incredibly sophisticated at pattern recognition. But because the library of patterns was incomplete, the tool encoded a dangerous bias. And the real-world consequence is that melanoma is already historically diagnosed later and has much higher mortality rates in patients with darker skin.
Which moves this from a fascinating algorithm problem to an urgent ethical crisis, especially with the explosion of teledermatology.
Exactly.
If someone uses a smartphone app to scan a suspicious mole, they need to know if the mathematical coordinate system running that app was ever even trained to recognize cancer on their specific skin color.
It perfectly illustrates how the oldest challenge in dermatology, accurately seeing and classifying the skin, remains the biggest challenge today, just amplified on a digital scale.
It is a profound realization. We've traced an unbelievable map today for you listening. We started with the violent ancient Greek origins of Derm and the elegant grammar of that T connector.
We did.
We discovered that your epidermis survives entirely by diffusion from the dermis. We unpacked the clinical stakes of Latin versus Greek in a TB test, witnessed the great morphology-pathology truce of the 19th century, and saw how the herpes virus maps the nervous system right onto the skin.
And we ended by seeing how modern AI is wrestling with those exact same visual blind spots.
It's just wild. It proves that the skin is infinitely more complex than just a biological wrapper.
It is a deeply encoded landscape. And before we close this deep dive, I want to leave you with one final mind-bending coordinate about your own skin to mull over.
Oh, please do.
It's the science of dermatoglyphics.
Fingerprint identification.
Exactly. Glyphs, meaning carvings, in the derma. The dermal ridge patterns that make up your unique fingerprints are structurally formed by the 24th week of fetal development. Before you are even born, that specific architectural pattern is set, and it never changes for the rest of your life.
Wait, really? It never changes?
Nope. The hands scale in size as you grow, obviously, but the topographical map remains perfectly mathematically identical.
That is amazing. So think about that today. Every time you pick up a coffee cup or turn a steering wheel or tap your phone screen, you are leaving behind an unalterable structural map of your very first weeks of existence. The permanent code of who you are stamped right there on the surface. We told you this deep dive would change how you look at your skin. Thanks for exploring the landscape with us.